So our next speaker is none other than Professor Surinder Pandav, who heads the Department of Ophthalmology at the Advanced Eye Center, PGI Chandigarh, and has been previously the Glaucoma Society of India president. And he'll be talking about the bent ab internal needle goniectomy, which is one of the most cost-effective surgeries for our population. So over to you, Dr. Pandav, please.
Thank you, Tanuj, and thank you, AIOS, for this opportunity. I have no financial interest in any of the devices that I'm going to mention. MIGS have been around for some time now, and I think they are going to stay because the scoring point for them is that their safety profile is very good, and they also produce significant lowering of IOP. Generally done for mild to moderate glaucoma, and where you also have a cataract, or if you want to reduce the number of medications, I think they are a good option. Now, bank procedure is easily available, so this is essentially the outline of my talk. Any surgical procedure should be easy to do, should be accessible, effective in lowering IOP. The cost is a big consideration, and of course, it has to be safe. So if you look at the bank procedure, it can be done by any glaucoma surgeon, actually. It does need training, no doubt about that. There's a bit of a learning curve. But procedure, once learned, it is not very difficult to perform. All you need is, most of the surgeons, they have the basic setup, and assuming a good microscope, as you learned in the first talk. And all you need is a direct gonioscope and some practice in looking at the angles in the operating room. And once that is done, additional equipment is just a needle, 25G needle, which doesn't cost you anything and is very easily available to most of us. And of course, with a little practice, important thing is to have a good visualization of the angle, use high magnification, and also bright illumination and the proper positioning of the patient. And once these elements are taken care of, the rest of the procedure is not very difficult, and you could actually, the bent needle can go into the Schlemm's canal and strip it off. The only complication that most often happens is a hyphema, which is quite common, and it's not to worry actually, because it also indicates that we are somewhere in the vicinity of the drainage channels, and which actually is in a way is a good thing. Now, if you look at the efficacy point of view, the outcome of the bang in primary open glaucoma is about 20% IOP reduction you can expect, and also a reduction of reduction in one anti-glaucoma medicine. So there's a significant decrease in IOP. Though we don't expect IOP decrease like we expect in trabeculectomy, but I think because it's the early and moderate disease where this much effect could be good enough. And to get some IOP, significant IOP lowering efficacy, at least 30 degrees goniectomy is required. But by and large, most of it be stripped up, 4 to 6 clock hours, which gives us the optimal results. And if you look at the bank procedure with KVD, which is very similar to actually bank, it also produces a significant lowering of the IOP. And also, if you compare the efficacy of the bank procedure with other MIGS, I think it is quite comparable, and we should expect around 20% IOP reduction, a little over 20% IOP reduction in, say, 73% of the patient with open angular glaucoma, so which is a good results for early to moderate disease. This is our own experience. This is actually the early experience when we started doing bank procedure, and initial 30 eyes. They were all kind of glaucoma patients, not necessarily POAG, but we had a mixed kind of, and they were all controlled with multiple drugs. So if you look at the IOP in the upper graph, there was a significant reduction from, say, about 8.5 to about 12. But more importantly, we saw a marked reduction in the number of anti-glaucoma medicines that we were using in the post-operative period. So that's, in that sense, is quite a satisfying results. Now, for this procedure to be effective, it is very important that procedure is done in a place where you have the collector channels, and this is very important for eye stent as well as the hydrus. The bank scores a little bit because you are you are removing a large part of the trabecular meshwork, and the probability of having a collector channel increases when you are doing a large stripping of the trabecular meshwork. So I think bank has an advantage here in terms of the location, of the collector channels over iStent. And the cost has all been mentioned. So the cost analysis is actually quite difficult to do, but I think this is from the basically from the U.S. data. So if you look at the TRAB within the first year of surgery, the trabeculectomy scores quite reasonable, but the iStent is very expensive. SLT actually the lowest, because SLT can also reduce intraocular pressure to similar extent as we are seeing with in the MIGS procedures. Among the MIGS procedure in this study, the trabectome, which is again somewhat similar to bang in a way, was found to be the most cost-effective in terms of cost reduction per millimeter of mercury IOP reduction. But if you go beyond first year, then I think the initial cost of the procedure is high, and if you take that away, then the IOP reduction cost is like 12 to 61 millimeters of mercury pressure. And again, the lower side is basically for the trabeculectomy group, and the higher side is for the bang or bang-like the MIGS procedures. So there's a big economic advantage in doing MIGS procedures, and this is the commentary which is published recently in IGO, and I think again they tried to convert figures for our consumption that in terms of INR. And if you see the trabeculectomy remains a reasonable option. Glaucoma drainage devices are a little expensive, but if you go to the iStent is the most expensive procedure, I think, if you look at the IOP, the cost of IOP reduction of 1 millimeter of mercury. So this is a very expensive procedure, and trabectome again is higher. The suture gap is very cheap, and the bang procedure, of course, whatever IOP reduction you get, is kind of more or less free of cost. So I think the bang score is very high if you look at the economy of the whole, the glaucoma surgery. The safety profile is very good and is, I would say, excellent. The only problem is hyphema that mostly we see on table, which is not very much of a consequence if you have a better patient selection and taken care of the anticoagulants that the patient is taking. Hyphema can occur in the post-operative period, but I think generally speaking, it's not much of a concern. Other complications could be the damage to the lens or damage to the iris or iodialysis, but they are rare, and I think its profile is very good. So to summarize, bang is available everywhere, easy to use, and if you look at the other options, they are really very expensive. So if you are thinking in terms of starting bang, MIGS surgery, I think it's better to start with the bang. Thank you very much.
Thank you, Dr. Pandav. So you gave a very nice message. All of us should start MIGS with a